Okay, welcome everybody to our sepsis work group today. My name is Rachel and I am one of the MVC site engagement coordinators. I'm very happy to be here today to facilitate the work group. This is our agenda for this work group today. I'll go through some housekeeping and P4P reminders. Then we will have a presentation from our Henry Ford Health Macomb site. And then following the presentation, we'll do a little discussion where you guys can ask your questions or talk about the presentation. And then we will end the work group with some MVC updates and upcoming events. So a few housekeeping items. Remember that we are recording this session. We will share the presentation slides and the recording with attendees following the work group. That will be in an email that will be sent out later in the afternoon. Also a reminder to please mute your microphone if you are not asking a question or, part of the discussion time. It just helps eliminate any background noise during the presentation. And then if you have questions throughout the presentation, please feel free to put them in the chat. We will be monitoring that and answering questions at the end during our discussion. A reminder for our P4P participating sites, we ask that you have active participation. This includes answering any discussion questions and then also participating in the discussion. At the end of the work group, we will have a post-work group survey that you will need to fill out and return to us to receive the engagement credit for the work group. The post-work group survey is also actually great for anybody who's not P4P participating as well, because it gives us a lot of good input on what you liked or what you didn't like about the work group. All right, today's presenters, we have Brandie DeVos, sepsis coordinator from Henry Ford Health Macomb, and she is presenting with Errin Couck, who is the HMS Sepsis Abstractor at Henry Ford Health Macomb. Brandie has been the sepsis coordinator for Henry Ford Macomb, and she has over 20 years of experience of process improvement in a variety of patient settings, which include quality, infection prevention, and women's health. Brandie's current position allows her the opportunity to organize and lead hospital staff whose responsibilities include early recognition and best practice care of sepsis patients. She received her bachelor's degree in nursing from Saginaw Valley State University and a master's in nursing administration from Benedictine University. Errin is the HMS Sepsis Abstractor for Henry Ford Health Macomb, and prior to joining HMS, she worked as a registered nurse on the medical telemetry unit for 13 years. Her clinical background includes direct patient care for acutely ill medical patients with various diagnoses that require continuous cardiac monitoring. Errin received her BSN from Oakland University School of Nursing. And with that, I will be turning over the presentation to Brandie to share what they've done on their ED process.
Good afternoon, everyone, and thank you for the warm welcome, Rachel. I'd like to start out by wishing everybody a happy Sepsis Awareness Month. Also, Errin and I, along with our team, have been able to collaborate and work on some quality projects together. Today, we'd like to share one of those with you, as well as our sepsis journey that we've been on. Next slide, please. So here at Henry Ford Macomb Hospital, we're a 366-bed community hospital with a level 2 trauma center. A primary stroke center and a nationally recognized cardiovascular center is just a part of our designations. Our newest expansion project expanded our multi-specialty ICU from 48 beds to 60 beds. Henry Ford Macomb is affiliated with Michigan State University, offering 8 graduate medical education residency programs. We celebrate our mixed model with many private and employed provider groups of medical staff, offering high quality care of our growing community. Next slide, please. And we don't have any disclosures or conflicts to share at this time, so I'd like to turn it over to Errin.
Hi, as Brandie said, my name is Errin and I am the HMS Abstractor. For this portion of the presentation, we are going to describe a structured triage process and prioritize patients with suspected sepsis, particularly those with abnormal vitals. We are going to examine the operational, clinical, and patient satisfaction outcomes associated with early sepsis recognition and expedited treatment area placement. And we are going to apply key strategies from our ED triage model to optimize sepsis performance metrics and improve patient care outcomes in the diverse emergency care settings. Next slide. So when we first started our project, we really did not have any structured triage process in place for sepsis patients. And we also knew that HMS was rolling out this new metric where they were grading hospitals and antibiotic delivery within 3 hours of arrival for septic shock patients. So our problem at the time was that patients were being placed throughout the ED regardless of their presenting symptoms, SIRS criteria, or any organ dysfunction that was identified when the patients first walked in through our doors. And there was no real process in place to prioritize the immediate placement of hypotensive patients. So because we had this lack of a cohesive sepsis triage process and there was no tool to help guide our staff, we had septic shock patients that were not being identified in a timely manner, and we weren't fully utilizing our critical care resources for those patients that really needed it from the start. So this lack of identifying that highest level of care for those patients, it really inhibited us from giving them the stat treatment that was really needed. Next slide. So the first thing we did was build our ED sepsis committee. In our original meetings, we sat down with the ED educator and learned more about our ED triage process. And through those meetings, we found that when patients first entered the ED, they would register and sit down in the waiting room until they were called back for triage. So we recognized that there was an opportunity there, and we decided to form our committee that could focus on improvements from both the ED walk-in triage and the EMS triage. So our team would meet right in the ER, and it consisted of the sepsis program physician, the sepsis coordinator, the HMS physician lead, HMS abstractor, the ED educator, the ED director, the ED management team, and the director of quality. So originally, our meetings were being held monthly, and we would discuss metrics, data, best practice, and any barriers. However, since implementation of our new processes, our meetings have decreased to every other month, and on the opposite months, we meet with our hospital steering committee. Next slide. So this is the new process that we created for our ED walk-in patients. Right after the patient enters the ED and is done registering, the patient will immediately get their vital signs checked now by an ED tech. So originally there was a closet right next to where the patient would arrive into the lobby, and we were able to turn that into a dedicated vital sign room. So this room is currently staffed from 11 a.m. to 11 p.m., and these are our peak volume hours. So if a patient is hypotensive, whether it be by a systolic less than 90 or a MAP less than 65, that patient will be transported directly to the triage nurse, where the patient will be made an ESI of 1 and then transported to the critical care unit. Otherwise, for a patient with stable vital signs after registration, they will sit in the lobby waiting room while waiting for assessment by the triage nurse. While waiting in the lobby, the patients will have their vital signs checked every 2 hours. If they're noted to be hypotensive, they will be immediately taken to the triage nurse. However, if their vital signs are stable and after they are triaged, the patient is found to have 2 SIRS plus a suspected infection, then that patient will be made an ESI of 2 and placed in any available room in the critical or acute care unit of the ED. Next slide. So we then looked at our EMS triage process. Historically, our EMS patients would come in and there was a gap while the EMS crew was looking for space to put the patient in a room or give the nurse report to. So we were able to carve out this dedicated room that holds 3 patients, and that is also open during our peak volume hours. So in their vital sign room, there is a nurse and a tech that is staffed, and they are able to take report on the patient immediately, get the patient's vitals and start the triage process. Prior to implementation, we were looking at triage wait times in the EMS area around 30 minutes, and that's gone down to about 10 minutes with this process. So the patient arrives, they will get their vitals right away, and then they will follow the same flow of the walk-in triage process. Next slide. For our material rollout, we had to disseminate this message to our staff. So at the time, we were rebuilding the staff within the ED, and so we decided to use our previously established communication methods. So our ED has 4 leader-led huddles per day that are led by the ED director, the ED manager, and the 2 ACMs. And with these leader-led huddles, they are able to hit each staff at the beginning of their shift. And this is one of the ways that they chose to spread this message. They also send out a weekly message on this when to work on Sunday evenings. And in these messages, they'll highlight some of the great moments from the week prior and what they are going to work on for the upcoming week. So they were able to add this message to those weekly messages. Our ED, in addition, leadership did follow-up messages with the staff when the patients would come in and they would get vitaled in under 2 minutes, and they would celebrate those with these great moments. They also would share with the staff what the EMS volume looked like and things that they were able to catch once they got into the triage area up and running. For example, like some patients that may have been missed in the field. So prior to implementation, the leadership had this discussion at the 4 huddles every day, 1 week prior. Once they got going, they sent out the congratulation messages on top of having leaders rounding hourly starting at 11 a.m. For the EMS triage, there was a manager physically in the room the first few weeks working out all of the kinks with the ED nurse and the ED technician. And then our ED educator has now included these 2 new processes in our new grad RN orientation. Next slide. So one of the first challenges with this process was staff pushback. It was a new process, and they were concerned that there would be a massive backup at the registration area. They were also concerned that other patients would have perceptions that patients could be jumping ahead of them. So there was a lot of encouragement given to the staff, and leadership did a lot of celebrating those small wins with them. They would also pull staff aside and let them know that just by changing the order of the vital signs that they got the patient back, faster, the patient was treated faster, and they showed them how much our metrics were improving. They would also recognize any staff that did a good job with this new process during those leader-led huddles. Before the implementation of this process, our new ED leadership found that there were newer untrained nurses in the triage area. Therefore, they did do a revamp of the triage education also. Our educator would meet with any triage-able nurse, and she did a one-on-one ESI training session to discuss appropriate ESI levels and ensure that the staff was actually capturing the severity of these patients. They also implemented a new requirement where at least 1 year of ED experience is required to triage patients. And they made a requirement where the triage nurse rotates, preferably every 4 hours, to decrease triage nurse fatigue. Next slide. So this is the data that we are excited to be able to present. You can see that 2 years ago with our HMS data collection for the delivery of antibiotics within 3 hours for our hypotensive sepsis patients, that we were consistently performing under the goal line you can see in yellow. So once we implemented this new triage process at the beginning of Q4 2024, that's when you see that first spike above the goal. And then in Q2 2025, which is when we implemented the EMS triage process, you can see that our performance increased even more. Therefore, you can see on this graph that there was a considerable improvement, and we were able to capture it because of the changes with our triage processes. Next slide. So in conclusion, for my section of this presentation, we were able to have additional impacts from our triage revamping. We had less complaints from our patients within our triage area. They were happier with the progression of their care, because they were being seen sooner by that ED technician. Our lobby patients also with this new process, 90% of them were having their vital signs obtained within the first 5 to 10 minutes of them walking into our campus. Our EMS patients, they were getting their vitals obtained, their triage completed, and they were being roomed in one of our ED spaces on an average of 12 minutes. And this was also a huge satisfier with our EMS colleagues because they were able to drop off the patient, have a handoff with the ER clinician at bedside, and get back on the road in a timely manner. And then, as you could see from the previous slide, we had that increase of antibiotics given within 3 hours for our septic shock patients of 36%. So we are really happy with everything we've been able to accomplish with these new ED triage processes. And with that said, I'm going to hand it over to Brandie.
Thank you, Errin. As a multiple hospital system, we've been able to use the higher reliability model as we implement the tools to help with sepsis. Our system team was chartered in 2021, where in 2021 also a system dashboard was developed on Power BI. In 22, the sepsis-related policies, guidelines, and protocols were streamlined, and we were able to launch the sepsis narrator checklist and our code sepsis across the system in the ED and inpatient settings. In 2023, business unit scorecards were developed and collaboration took place to add the women's health units to our code sepsis activation. And then in 2024, we were able to strengthen our work stream teams and introduce our comprehensive CMS SEP1 dashboard and worked on our EMR workflows and alerts. Lastly, in 2025, we began to collaborate with new joint venture hospitals. And here on the screen is just a few examples of the areas that we've implemented. If you can kind of look above, you can kind of see like the forcing functions is that our practice advisories, the automation and computerization is our order sets, quick lists, and sepsis dashboard. Standardization is our code sepsis and our rapid response. Redundancy is our sepsis steering committee. Reminders and checklists, this is our epic narrator. Rules and policies, the sepsis policies, HMS sepsis goals. And then education and information. This is our RN, nursing assistant and provider education, as well as the suggestions to be more careful and vigilant is our sepsis coordinator and abstractor reviews. Just wanted to show you a few of the different tools that we use here at Macomb as well as at a system level. Here's the code sepsis activation tool. Anyone can call a code sepsis within our hospital. Severe sepsis and septic shock can be triggered by the Our Practice Advisory and EPIC. If there's a suspected sepsis and the patient becomes hypotensive, or if the treating clinician or RN recognizes that end organ dysfunction. First, we have here on the left side, the emergency department. You can either be a call to the operator or the health unit coordinator can send out a page with the MRN to the code sepsis team. And an overhead alert is called. The ED clinician, bedside RN, sepsis nurse champion, and the charge nurse can huddle with the patient at the bedside and determine the best practice treatment for the patient according to our sepsis policy. And then on the pregnant and postpartum and inpatient units, the unit clerk will call a 4114 and the operator will alert the rapid response team. Our rapid response team consists of an advanced practice provider, a rapid response nurse, a phlebotomy tech, a bedside RN, and the clinician if available. In the ICU, a little bit different here, a silent code sepsis is called by notifying the ICU resident. The resident will evaluate the patient with the nurse at the bedside. Then best practice care is ordered according to the sepsis policy. Next slide. Here is our best practice advisory or our best practice advisory, what has changed to recent. This is set up for the ED, inpatient, and maternal units. The inpatient suspected OPA utilizes the sepsis predictive model along with the SIRS criteria. The maternal OPA allows for documentation directly to the flow rows. This is something that we're actually working on updating and changing a little bit. Next slide, please. And this is our severe sepsis and septic shock OPA. This criteria, the OPA fires in the ED and the inpatient units when there's 2 out of 4 SIRS criteria and then one of the organ dysfunctions. The nurses and providers can choose one of the buttons below to acknowledge what is happening with the patient. Again, this is a process that we're updating currently as a system. Next slide, please. Also, something that we found helpful, we were able to mimic this off of our Detroit site, was the ED Sepsis Champion implementation. In June of 2024, we were able to implement this program. It's available 24 hours a day in the ED. Each of the RNs are educated and provided resources on best practice care. They're also an expert level on utilizing the tools to allow the additional resources for the staff, which creates a supportive culture in the ED. Once the sepsis champions were in place, we've seen more code sepsis being called and an increase in bundle compliance. We also utilize an awards and recognition program weekly to recognize their successes in the ED. And as you can see, so far year to date in 2025, we've seen a 10.5% increase in usage. Next slide, please. This is our sepsis narrator. It's a checklist that we spoke about earlier, but the checklist is interactive and changes from gray to green when the orders are signed off in the brain section of our Epic. There's also red alerts to flag for safety. For example, if the patient's hypotensive or an additional lactate is required. Next slide, please. With all the tools and work that we've done at a system and a hospital level, as you can see, that work has paid off. It's really helped our CMS Sep 1 compliance. It's steadily increased from 2022 to our current year in 2025. Next slide, please. This is a sample of provider feedback that we provide our physicians and residents with. Each of the physicians and residents are given a sample of cases that passed or fell out according to both the CMS and HMS metrics. We're able to track this in real time as well as retrospectively and give them the opportunity to ask questions and learn how to improve. We also celebrate their victories by choosing sepsis stars each month and give rewards and recognition. We have a little pin that we give each of the residents and the doctors. It's kind of been a fun little competition down in the ED with who gets their little gold pin next. And next slide, please. Lastly, I would like to share our why with you. This slide indicates the total amount of lives that have been saved since 2021. And next slide, please. I would just like to thank you, and Errin and I would like to entertain any questions that you might have regarding our sepsis program.
All right. Well, thank you so much, Brandie and Errin. That was really great, super informative. And I like that you shared a lot of the tools and steps you guys took to complete that project. All right. If anybody wants to talk, you can raise your hand and I'll call on you. Or if you'd like, you can put your question in the chat. It looks like Andrew has a question. Were sepsis champions the RNs or MDs?
So we have a little bit of both. The actual sepsis champion program was the RNs. There's one on every shift that's available. But we've also had, I have a sepsis champion that's an ED physician down there that's also available to ask questions at any time as well.
Awesome, thank you. It looks like Amanda is asking that you mentioned you're able to track the compliance in real time, and how is this done?
These are done with daily abstractions. Usually in the morning, I'll start out and look at the cases that are currently in the ER just because we have the most chance for improvement at that time, and then go back retrospectively. I have quite a few sepsis cases, so I'm able to just sample, but mostly all of the code sepsises that are called in the inpatient units are for sure reviewed. Then followed by the ED. And then we also look at our fallouts and look for improvements as well. So that's the retrospective side.
Okay. It looks like Corey has a question. Did you include sepsis bundle compliance in physician OPPE to help during beginning the project? Do you need clarification on that one?
Yeah.
Okay. Corey, can you clarify a little bit about what you mean by the physician OPPE?
Sure. So at Bell here in Ishpeming, for the physician compliance, we only have a few physicians in the emergency department. And we've been working with sepsis, and one of the recommendations was to add it to the physician OPPE in order to increase the compliance, especially with two of the specific providers. And I was just wondering if anybody utilized OPPE as kind of a motivator for sepsis bundle compliance and how that worked.
So we didn't necessarily use that tool. Currently, we try to give feedback. We do at this time use blinded data, just so that the other providers are not seeing each of the providers just to kind of start out. We do plan on changing that in the future, but we haven't used any kind of tool specifically like that.
Thank you. Errin has a question. Are the sepsis champions, is it their sole job, sepsis recognition, or what does their role entail?
So they are on shift. So they're not able to attend every single code sepsis. However, all of our shift leads are trained as well. So they're able to step in, but we do give them a little bit of a hourly reimbursement to be able to help. And it's really helped. And I think that one of the biggest things that it's helped is it's more colleague to colleague instead of having somebody above them. And then they bring the questions to me, or they'll send me a page if they have further questions. But it seems like they're a little bit more receptive to each other.
Thank you. And then Amanda has a question. Is the code sepsis reliant on someone documenting that, or like a time zero, or is it auto-generated?
So ours is auto-generated, and we use the time that the OPA goes off. However, they do have to open the checklist for us to get credit, for utilizing that. There's a timestamp that they put in when they open it. And that's probably one of our most difficult things to actually get them to open it. Based on our metrics and our compliance levels, we can see that they're using it, but to actually click on that, that's probably our biggest gap.
All right. Are the sepsis champions different than the sepsis coordinator role?
Yeah, so we have one coordinator for the hospital, which is myself. And then the sepsis champion are ED nurses, and there's one on each shift.
Let's see. Looks like Tammy has a comment. We have tried to use the OPPE reports, but our SEP1 numbers were too low to be significant at the provider level. We share overall SEP1 compliance rates and data on our HMS performance measures. Not really a question, but thank you for contributing, Tammy. Dallas has a question. Did you mention that the critical areas that house 3 critical sepsis patients is staffed by an RN and a tech? If so, how did you get approval for additional staffing? If not, can you repeat what you mentioned about this? Thanks.
So the EMS triage area, that is staffed by the ED nurse and an ED technician, and we did not receive approval for additional staffing. They just got creative with moving around their technicians and their nurses to ensure that there was the nurse and the tech in that area, because we found that the improvement from that was very beneficial.
Awesome. Thanks, Errin. Okay. Let me pull up here. I think I've got a couple questions might be able to add in here. For Brandie and Errin, I know that you had mentioned you had some staff pushback when you were first implementing, and then you guys had some really great ideas for kind of helping staff get positive feedback on how they were doing with the new project and everything. Were you able to get any feedback from the staff about their thoughts after seeing the successes and seeing how things kind of turned around and improved?
Brandy's down in the ED more than me, so she might have more feedback on that. But I know from our ED director, she said that the staff has really appreciated this new change because, the patients are happier. And like I said, we're getting our patients back into those areas quicker. They're being treated faster, and we're having a lot of positive um, improvements from it.
I think as far as feedback from the staff, one of the big things is getting the patient to the appropriate level of care initially, and they're able to use more of their staffing matrix a little bit better. And they're also finding that they're recognizing not only sepsis, but also strokes, MI, and some of the other key components a lot sooner with those vitals. They also, there was a little bit of gap before where there would be where the EMS would bring them in and that nurse could get to the patient. Now there's eyes on that patient immediately. So that kind of closed that gap as well. So it's been very positive.
Nice. That's great. Um, and then, okay, let me check the chat really quick. Okay, no extra questions. I'll do my other question then. Let's see. Just going to make sure we haven't already answered my question. Oh, okay. So your sepsis compliance rate has greatly improved since introducing the new process. Um, has this thorough approach of sepsis care maintained its way through the patient's continuum of care? Like, have you seen any impact in sepsis readmissions since the implementation?
That's kind of like the next level of what we're going to look at next. Length of stay as well as readmissions is kind of on the agenda to look at next. But we've definitely seen improvements and have been satisfied with where we've been so far.
Okay, awesome. All right. Well, if nobody else has any more questions, I'll give everybody a second to pipe up if they do. I don't see any hands raised. Oh, chat moved along. Abby has a question. You mentioned that you're working on updating your suspected sepsis and severe sepsis septic shock OPA. Can you share what you are working on, and what would you like to improve?
So that's something that our system level is working on. There's a committee that's been working really hard on that. And basically, what they're trying to do is make it to lower the nurse fatigue because that goes off quite often, that OPA. So they're on the inpatient side looking at that suspected sepsis, more the questions underneath when it will shut off and when it will refire, and also allowing them to document right from that screen.
All right. Thank you, Abby, for the question. Okay, it looks like chat is winding down, so I'm going to go ahead and move on to our MVC updates. If I can get my windows to cooperate here. Okay. All right, so we are looking at our upcoming work groups for MVC. September, we have one more work group on the 25th. It's a health and action work group. This one is actually going to be a presentation by our very own Emily, who's the site engagement coordinator. She will be going over the most recent common conditions push report that was sent out from MVC. And she'll kind of walk through the report and then also share some ways to find certain data within the MVC registry that is relevant to that report. And then in October, we have our fall collaborative wide meeting on October 10th. Registration is open for that, and the link for registering will come through the follow-up email for this work group today, but it is also available on our website if you'd like to register. And just, let's see. I think did we have a deadline for that, Jessica? Was that the 25th?
For the collaborative wide meeting registration?
Yeah.
Yes,
Yeah.
that will close September 25th.
25th. Okay.
I was just typing it in the chat, but since I'm speaking, we're also doing a networking dinner the evening before. For anyone that would be interested in registering for that, we can share that out as well.
Thank you. And then we've got quite a few other work groups coming up, October, November, and December. So we'd love to see you all there. Again, the registration links will be available in the email that I send out later today. And upcoming events, just a reminder for any site visit requests for 2025. The last day will be September 30th for those to come through. And they will be after the collaborative wide meeting. So just keep that in mind if you do plan on requesting that. And then again, on the 10th is our collaborative wide meeting. And we are now looking for presenters for 2026. So if you do have an work group presentation idea for next year, it's kind of weird to say that already. We'd love to hear about it. You'll be able to submit through the link in the slides, but I can also put that in the email as well, because we start doing work groups in January. So definitely looking for presenters. All right, with that, thank you so much. Thank you, Brandie, and thank you, Errin, for that great presentation. We really appreciate it. Emily's going to put the post-work group survey link in the chat for you all. And whether you do P4P or not, it would be great if you filled that out. We'd love to hear from you and what your thoughts were from the work group today. Thank you so much and have a great rest of your day.